Rib fracture fixation, navigating the guidelines for optimal care. Introduction. Rib fractures are common injuries, often resulting from blunt trauma. Surgical fixation has become a consideration for specific cases, particularly in managing complications like flail chest. Overall rib fracture. Definition. A rib fracture is a break in one or more of the rib bones in the thoracic skeleton. These injuries are common, particularly as a result of blunt force trauma. Causes. Major trauma. The most frequent causes of rib fractures include motor vehicle accidents and falls. Minor trauma. Rib fractures can also occur from less severe incidents, such as falls from standing height, especially in older adults. Non-traumatic causes. Conditions like severe coughing or repetitive movements can lead to fractures, particularly in individuals with weakened bones. Clinical presentation. Pain. Localized pain at the site of the fracture, which worsens with movement, deep breathing, or coughing. Difficulty breathing. Patients may experience shortness of breath due to pain or lung complications. Visible deformity. In cases of displaced fractures, there may be visible deformities in the chest wall. Complications of rib fracture. Rib fractures can lead to several serious complications. Pneumothorax, collapsed lung. Hemothorax, bleeding into the pleural cavity. Pulmonary contusion, bruising of lung tissue. Flail chest, increased risk of pneumonia. Patients may not clear secretions effectively due to shallow breathing from pain, increasing pneumonia risk. Indications per current guidelines. Surgical fixation is generally indicated in the following scenarios. Flail chest, defined as 3 or more consecutive ribs fractured in 2 or more places. Severe displacement, fractures with significant overlap, greater than 15 mm, or displacement. Multiple rib fractures, particularly when 5 or more ribs are involved, especially if requiring mechanical ventilation. Recommended for patients with greater than or equal to 5 rib fractures and flail chest requiring mechanical ventilation. Symptomatic non-union of rib fractures. Severe displacement found during thoracotomy for other reasons. Considered for greater than or equal to 3 rib flail not requiring mechanical ventilation. Greater than or equal to 3 ribs with severely displaced fractures or moderate displacement causing significant pulmonary function reduction despite optimal pain management. Contraindications. Absolute contraindications. Contaminated surgical field. Relative contraindications. Severe lung contusion requiring prolonged mechanical ventilation. High cervical spine injury requiring mechanical ventilation. Diagnosis. Physical examination. Assessment for tenderness, crepitus, and respiratory distress. Imaging studies. Chest X-ray. First-line imaging to identify rib fractures and associated complications. CT scan. Used for a more detailed evaluation of lung parenchyma and 3D reconstruction of the rib cage. Ultrasonography. To localize fracture during surgery and plan targeted incision. Treatment overview. Conservative management. Most rib fractures heal with rest, pain control, NSAIDs, and breathing exercises to prevent complications. Surgical intervention. This is indicated in cases of flail chest or severe displacement that compromises respiratory function and as per guidelines indications. Conservative management and pain control. Pain management. Initial analgesics. Acetaminophen, 1000 mg post/4 every 8 hours as a base analgesic. Nonsteroidal anti-inflammatory drugs, such as ibuprofen or ketorolac. Weak opioids, such as codeine or tramadol for moderate pain. Opioid management. Patient-controlled analgesia, PCA morphine is preferred for significant pain. The dosing should be carefully monitored to avoid excessive opioid use. Breakthrough pain, strong opioids, example hydromorphone. Regional anesthesia techniques. Thoracic epidural analgesia, considered the gold standard for severe pain. Paravertebral blocks and serratus plane blocks, these techniques can provide effective analgesia with fewer side effects compared to systemic opioids. Respiratory support. Maintaining respiratory function is critical in patients with rib fractures. Incentive spirometry should be used in all non-intubated patients to encourage deep breathing and prevent atelectasis. Monitoring respiratory status, regular assessment of vital signs, oxygen saturation, and respiratory effort is essential to identify any deterioration early. Early mobilization. Encouraging early mobilization helps improve lung function and reduces the risk of complications. Patients should be assisted in sitting up or walking as soon as they are stable enough to do so. Surgical intervention. 1. Surgical stabilization of rib fractures, SSRF. Overview. SSRF involves the use of various fixation devices to stabilize fractured ribs and restore chest wall integrity. Indications, typically indicated for patients with flail chest, multiple displaced rib fractures, or those who fail conservative management. 2. Plating systems. Pre-contoured plates. These are specifically designed plates that conform to the anatomical shape of the ribs. They are often used for stabilizing fractures in the 3rd to 8th ribs. Materials. Titanium is commonly used due to its strength and biocompatibility. Locking plates. Plates equipped with threaded holes that allow for locking screws, providing enhanced stability and fixation strength. Polymer cable circlage. Used in conjunction with plating systems, especially for longitudinal fractures or osteoporotic ribs. This technique helps secure the rib fragments more effectively. 3. Intramedullary fixation devices. Overview. These devices are inserted into the medullary canal of the rib, providing internal stabilization without extensive exposure. Benefits. A minimally invasive approach that reduces muscle trauma and postoperative pain. 4. Video-assisted thoracoscopic surgery, VATS. Technique. A minimally invasive surgical approach that allows for direct visualization and access to rib fractures through small incisions. Applications. VATS can be used for both diagnostic and therapeutic purposes, including bleeding control and rib stabilization. 5. Muscle-sparing techniques. Approach. Techniques that minimize muscle dissection during surgery to reduce postoperative morbidity. Benefits. These techniques help preserve muscle function and reduce pain by avoiding significant muscle transection. 6. 3D printing technology. Application. Utilized for preoperative planning and creating patient-specific implants that match the anatomical contours of the fracture site. Future directions. This technology is expected to enhance surgical outcomes by prognosis of rib fractures after conservative and surgical interventions. Conservative treatment primarily involves pain management, respiratory support, and physical therapy. Advantage. Avoids the risk of surgery. Disadvantages. Prolonged hospital stay. Complications such as malunion or non-union of fractures, atelectasis, and pneumonia due to inadequate pain control and respiratory function. Delayed hemopneumothorax and atelectasis. Chronic pain. Surgical stabilization of rib fractures, SSRF. Advantages. Shorter ICU stay, ventilator dependency, and hospital stay if early intervention within 48 hours. Lower pain scores postoperatively compared to those managed conservatively. Disadvantages. Although surgical intervention carries risks such as infection or hardware-related issues, studies indicate that the overall complication rate is lower in surgically treated patients compared to those receiving conservative management. Thank you.